MDS and leukemia. We're going to have a lot of fun. You know, we're going to talk about the things that I want to talk about because I'm giving the lecture. So take that, Joe Susie. All right, so try to keep it as informal as possible, I guess. You know, feel free to interrupt whenever. I have a rough idea of what I'm hoping to get through today. You know, we'll start over with a little schema of the bone marrow and how we fit MDS and leukemia into that schema. We'll talk about MDS first. And my true feeling is if you understand MDS, you understand leukemia, or at least AML. And so after MDS, we'll talk a little bit about leukemia. We'll talk about mostly like, you know, how to classify it and in a rough approach to therapy. We'll try to not go into the nitty gritty. And then we'll talk about some complications of therapy. We'll have some mix-up questions throughout. And then if we have time, we'll talk about long-term stuff too. Okay, so let's talk about the bone marrow. And, you know, if there's one of the things that I'm hoping that people have gained, and this is not just from today's lecture, it's as a standalone topic, but through the morning reports you've had with me, talking about how to think about the bone marrow. Let's, you know, we simplify what the bone marrow is, right? There's really two lineages that are happening inside the bone marrow. There's the myeloid lineage over here, and then there's the lymphoid lineage over here. We're going to ignore the lymphoid lineage for now, but the myeloid lineage, we really only need to know about three cell lines that are given rise to by our myeloid precursor. So this stem cell here gives rise to white blood cells, or the myeloblast, platelets through the megakaryocytes, and then of course red blood cells here. So you know, basically the three cell lines that we see in our normal CBC, right? The WBCs, the hemoglobin, and the platelets. Those are the three cell lines that are created by the myeloid precursor cell. And then there's a lymphoid, and that gives rise to your T, B cells, and NK cells. The way I think about it, the bone marrow, is that its job is to create those three cell lines. And through life in general, what happens is that the human body and any cells in the human body acquire mutations. Some sort of changes occur in the cell cycle, right? Your typical like G1, S, G2, M, right? G1, G2. Like your typical cell cycle goes through synthesis, mitosis, synthesis, mitosis, synthesis, mitosis. Now, during these like kind of growth and differentiation phases, like G1, that's when some sort of environmental insult could happen and change the DNA so that when it's synthesized and mitosis happens, there could be dysregulation of that process. The bone marrow is supposed to create these highly specified cell lines, but mutations can either speed up that process or slow it down. Those are the only two things that could possibly happen, right? Either things get sped up or they slow down. So we'll talk about that in a second too. If they speed up and you're still creating differentiated cells, those are called MPNs. That's what an MPN is, right? It's just creation of, that's a proliferative neoplasm, a myeloproliferative neoplasm. If you create too many white blood cells, think about like CML, you're thinking about too many platelets being made, essential thrombocytosis, too many red blood cells, polycythemia, right? And if it slows down and you're not having differentiation, and instead you're just creating a bunch of undifferentiated cells, also known as blasts, that is, in a nutshell, what MDS is, right? So before I also move on, thinking about how cells are classified and identified is also a big problem too. Nowadays, we have a lot of nitty-gritty details that we can gain from a cell. Back in the day, the only thing we really had were pictures, right? We could look at it under a microscope and see, hey, this cell doesn't look very differentiated, the blast here. And this is the normal process of differentiation. I just picked the neutrophil as an example, but you can imagine you could replace this cell with like, a red blood cell precursor, like a proerythroblast and its, journey into becoming an erythrocyte, and a megakaryoblast into a megakaryocyte and into platelets, that kind of thing. But really, it's a very similar process, right? So identification of a cell used to just be on morphology. So that's usually what we only had, morphology. And that is what a cell looks like under a microscope. And you can see that these cells have a high N to C ratio, right? Very large, fluffy, eukaryocytic, chromatin, all that stuff. And as they mature, this nucleus becomes more dense and compact. And so that helped people identify cells that were immature. Nowadays, in addition to that, we're able to also identify little receptors on top of the cells. And these little receptors would cluster together and help us differentiate cells. So a cluster of differentiation, which is what a CD marker is. That's what CD markers really mean, right? A CD marker is a cluster of differentiation. And then we just numbered them based off of when we identified them, from like 1 to 30s and like into the 100s. And in addition to that, we now also are able to look at the genetic material in the nucleus and compare it to normal and see, are there differences in how the chromosomes look? You know, is there like a extra limb? Is there too many copies? So that's the karyotype. And we can now also look at the actual sequence, the TCA, whatever, and see that, oh, look at that. There's a mutation and this is replaced by a G or something like that. And that's called the cytogenetics. And these clusters of differentiation is called the immunophenotype. So there's the morphology. That's how the cell looks like under a microscope. So that's like kind of like bigger scale stuff. We then can also look at the cell surface for CD markers, or the immunophenotype. And we can then look at the nucleus and look at the mutations that have occurred, and that's the cytogenetics. So in that order, from macro to micro, we're able to identify abnormal cells. And an abnormal cell, another way of saying that, is a dysplastic cell. And if you remember back to med school, like a dysplastic cell is essentially a cell that is incapable of differentiation, is typically immature, and we're always thinking is like a precursor to malignancy, right? Dysplasia, we always worry, could lead to cancer. Right. So MDS in a nutshell, the way I think about it is, here we have our blast. Blast is typically not an abnormal cell, right? It's supposed to go down this pathway into differentiation. If a mutation occurs, some sort of environmental injury or inborn illness, this blast, instead of being pushed towards differentiation, starts entering, it's being shunted towards these like dysplastic cells, and then these blasts then proliferate. Okay. All right, so thinking about MDS and what we need to know about MDS, we kind of talked about the pathophysiology of how it comes about. So to summarize, how can MDS be caused? There's primary or secondary causes. Oh, this one left, whatever. Let's just pull up the participants. No. Sorry. Anybody have, so summarizing what we already talked about, what are some of the primary causes of MDS that we can think about in broad strokes? What do you guys think? You know who's an expert on this? Tudor. Tudor, what do you think is a primary cause of MDS? Oh,
primary cause of MDS?
Yeah, what causes primary MDS?
I mean, I think it's just an idiopathic process brought on by myelofibrosis as a process of aging.
Sure, yeah, I think you're on the money there. So when I think about primary MDS, these are things like genetic mutations, right? Something that could happen from aging, sure, but can even be congenital. Secondary is secondary to an insult. So Candace is definitely right on the money there. When thinking about secondary MDS, you know, culprits include radiation, chemo, and what's the word I'm looking for? Environmental toxins too. The one that I think people need to know about is like benzene is a commonly tested one. Okay. All right, so presenting symptoms just in broad strokes too, very nonspecific. What happens in MDS is, you know, these are patients that definitionally speaking, the definition of MDS is really less than, oops, why is that not working? So less than 20% blasts in the bone marrow with cytopenias. And when we think about cytopenias, that extends back to how we thought about the bone marrow schema, right? So going back to how the bone marrow is evaluated, there's really only 3 cell lines, right? There's either white blood cells, hemoglobin, or platelets. Those are the 3 cell lines that the myeloid stem cell is responsible for. If we have MDS, which is going to slow the process of you know, differentiation, we're going to have cytopenias or a decrease in any one of these, or if not all 3 of these cell lines. So that's what cytopenias are referring to. As far as thinking about most commonly seen, does anybody know what the most common type of cytopenia in MDS is?
Anemia?
Yes, exactly. So anemia, specifically macrocytic anemia, is the most common, what's it called? Associated symptom sign of MDS. And I think what's happening in everybody's minds right now is thinking, hey, wait, if macrocytic anemia is a common finding, or anemia in general, or even cytopenias in general, how do I, as a medicine doctor, evaluate somebody for MDS? So up on my little list here, I've got 4 things I think about when it comes to evaluation of MDS. And you guys can either type them in the chat or you know, voice them yourselves. But what are kind of in a stepwise approach the tests that I like to get in everybody who I'm thinking about might have MDS? I'll help you guys out, and I'll tell you the first one is a CBC with a diff. So what else? Okay, I see bone marrow biopsy. I'm going to put that down here at the end. So definitely agree, it is necessary. But there's a few things as medicine doctors, because we don't do bone marrows ourselves, right? Very good from Allison and Amanda. So every patient who I'm thinking about might have MDS, and honestly, every patient, in my estimation, where it's not clear the source of an anemia, should get a smear. So peripheral blood smear is very important. And when we look at the peripheral smear, remember, dysplasia just means abnormal cells, right? So what we expect to see on a CBC with a diff or a smear is we expect to see the cell lines could be down, either all 3 or one of them, most commonly anemia. And we'll see dysplastic or abnormal cells in the smear, including pathognomically the pseudo-Pelger Hewitt cells. I forgot to put an image in here. I meant to, but it looks like essentially a cell with like little sunglasses. What else? Now, this is somebody who, what about evaluation of macrocytic anemia? What test does somebody who have, you know, macrocytic anemia need? I agree, Eric, Retix, we'll throw that in with the CBC, you know, Retix is always a good idea. But macrocytic anemia with cytopenias, everybody should get these. Yes, exactly, Candice, very good. We should always check for a B12. And in my personal practice, although it's not as cost conscious, I like to just check a folate in these patients if they have macrocytic anemia and cytopenias. And then the last test, now after the other all these tests have been done. The other thing I like to always evaluate for patients who have cytopenias and macrocytic anemia is to rule them out for things like HIV and HEP, both B and C. So these patients deserve to be evaluated for these concurrent viral illnesses because these can be bone marrow suppressive and mutagenic too. If all of this testing is pointing towards MDS, then my next specialty test come by, and that the stepwise approach, and what I'd like to do is peripheral flow first, and then you know, a bone marrow biopsy. And the bone marrow is really looking for what we talked about here, is identifying these blasts, these abnormal cells, and the sources of the cytopenia. And really the peripheral flow is doing the same thing, just doing it in a non-invasive way. And just to remind everybody what a peripheral flow is, all it's doing is, remember calling back to the immunophenotype and those CD markers, is it will check two CD markers against each other. So let's say CD20 and CD19, you know, normal B cells co-express both of these. They might check CD like 8 with 20, so we shouldn't see both B and T cell markers together on the same cells. And all it does is then it will subdivide the cells into the, you know, those populations if it's positive or negative. And so cells that are in this corner will have both 8 and 19. So this is an abnormal population. So this is weird. Any cells that are here, because they're both 8 and 19 positive, that shouldn't happen. Okay. Once we have evaluated for possible other causes of, you know, macrocytic anemia or MDS, we have this flow or bone marrow, we have the blasts in front of us, we're going to think about calling this MDS. We also now have to think about classifying that MDS. And there's 6 major categories that you know, exist. And you don't really need to know all of these in exhaustive detail. I just want you to know that MDS, you know, there is more specification. So especially when you're on your like Blue 1-2 services, a question you should have to ask yourself is, what kind of MDS do they have? Because depending on the type of MDS, their therapy and prognosis changes. So that's the only reason to know about this. The 6 categories, again, there's refractory anemia with excess blasts. That's what RAED means. So refractory anemia with excess blasts type 1 or type 2. There's multilineage dysplasia. So MDS with multilineage dysplasia, that's what MLD stands for. And then MDS with single lineage dysplasia, that's SLD. And MDS with ring sideroblasts. MDS with 5q minus mutation. And then MDS not otherwise specified. The reason, so I've organized them this way is in order of like down here. So this is actually the most common cause, and this is the least common cause. So about 80% of your MDSs fall into one of these 3 categories. So you can see that multilineage dysplasia or more than one cytopenia is more common than single lineage. That makes sense, right? Because our blasts, our precursors are higher up the chain, giving rise to all these different cell types. And then, you know, there's these ring sideroblasts, like phenotypically what they look like. And then 5q minus comes into that picture as well. These being, you know, the other thing I wanted to just point out here is you'll see that this is why our definition of MDS is like less than 20%, because typically MDS has only around 5% blasts in the bone marrow. That's what's going to be present for these guys. But the excess blast phenotypes have up to 19%. Depending on what type of MDS they have, so what, you know, the type, we also care about how much their cell lines are being affected, right? So how cytopenic are they? Are they neutropenic, anemic, and thrombocytopenic? And then on top of that, you know, their age. This type of stuff all together helps us prognosticate. You don't have to know this, but it's like, I think it's called like the IPSS score. It gives you a score out of 6. And essentially, the more cell lines involved, the older you are. These patients, you know, the higher the score is, like we'll say is high risk disease. Patients with high risk MDS, their median survival is less than a year. And people with low risk disease, their median survival is about 9 years. let's say a decade. So you can see that it varies very much so depending on how many mutations you have and the other stuff. And in general, for both MDS and AML, ALL, really any type of cancer that's ever existed, more mutations are bad. So always remember that too. And how do you acquire more mutations? Time, right? So anybody who's older with the same mutations, they're gonna have a bad time. Okay, let's do a question. I'll read it out loud while you guys are thinking about it too. Or unless we have any volunteers. Anybody want to read this question?
I can read it.
Ray, Lauren, do it.
All right. A 74-year-old man is evaluated in follow-up for myelodysplastic syndrome diagnosed 3 months ago. Cytogenetic studies and fluorescence in situ hybridization show deletion of 5q. It was determined he has low-risk MDS by the revised International Prognostic Scoring System. He requires erythrocyte transfusions every 2 weeks to prevent symptomatic anemia. He takes no medications. On physical exam, his pulse is 120, respiratory rate's 24. Other vital signs are within normal limits. His skin is pale, and cardiac exam reveals tachycardia. Labs show a hemoglobin of 6.5, leukocyte count of 2,500, platelet count of 220. Which of the following is the most appropriate treatment?
All right. I'm looking at screens, and then you can also type it in the chat what you guys think is going on. So who votes for A? I think I got like maybe 1 or 2 votes for transplant. Okay. Who votes for B, which is thymocyte, globulin, and cyclosporine? Got no votes for B. Who thinks the answer is C, imatinib? No votes for that. And who thinks the answer is D, lenalidomide? I got maybe 3 or 4 votes for that. So the correct answer here is lenalidomide. Oops. Lenalidomide, yay. Joe, I saw that you voted for lenalidomide. Could you explain why you thought that was the answer?
The one part that I remembered is that there's like the 5q component.
Very good. Yeah, exactly. So remember, 5q is a specific category of MDS. And the reason they made it a specific category of MDS is because it's a targetable mutation. Typically, people with the 5q minus disease, they have a slow burn MDS. And MDS in general, also as a rule of thumb, to differentiate it from leukemia, is it's a slow burn. It's like a slower process disease. You have more time for mutations to accumulate, and then eventually it can turn into leukemia as those mutations accumulate, right? And we'll talk about that in a second too. Right, so thinking about the general approach to treating MDS, and just for, like lenalidomide is the treatment of choice for people who have like 5q minus mutations in MDS. Imatinib is a tyrosine kinase inhibitor, so that's like the treatment of choice for things like CML, which targeting like that 922 translocation. Anti-thymocyte globulin and cyclosporine, does anybody know what that treats? And does that, what do you, I'll give you a hint. It has anemia.
Is it for like a thymoma?
Good guess. It's actually aplastic anemia. Weird disease, right? And then a transplant, I think we all realized, I just don't have enough time to go into the treatment rationale, but we'll talk about aplastic anemia during one of our morning reports at some point, I'm sure. In any case, I think we all realized that this guy probably wasn't sick enough to get a transplant, but everybody realized he was sick enough to get treatment. So how do we approach treatment for MDS? you know, I would point you to how I remember the two goals of therapy for MDS. The two things that we try to do is we try to limit the number of transfusions. We also try to limit the possibility of transformation. So transfusion, transformation. Transfusion, what I mean by that is trying to decrease the number of, like, you know, packed red blood cells or platelets that a patient may need. Transformation means evaluating the MDS for risk of becoming AML. So who to treat is anybody who needs lots of transfusions and who is deemed to be at high risk. And remember, if we go back to here, we use that like IPSS, the prognostic system, to help risk stratify our patients. Thinking about how to treat it then, so once we've identified these high-risk patients, the only thing you really need to know about is for these patients who have like low-risk MDS without a targeted mutation, typically these patients are just treated with like transfusion support and maybe like Epogen, at least first line. And if their transfusional support becomes high enough, or if they become high-risk MDS patients, they're treated with a hypomethylating agent. So something like decitabine or azacitidine with transfusions. And then if it's high enough or refractory, you know, we'll try to get them to a transplant. Okay. All right. Another question. I changed this up from Mixapp a little bit. Instead of describing it, I gave you a picture. Any takers on reading?
I'll read for you, Navi.
Oh, thank you, Joe.
A 35-year-old man is evaluated in the ED for fever and epistaxis. He has been experiencing malaise for several weeks and fevers, chills, and anorexia for the past 3 days. Today, he developed epistaxis. He takes no medications. On physical exam, his temp is 100.4, blood pressure is 105/70, heart rate 110, respiratory rate of 24. He's diaphoretic. Dried blood is noted in the nares, and gingival bleeding is present. No lymphadenopathy or hepatosplenomegaly is noted. He has petechiae bilaterally on the lower extremities. Peripheral smear is shown.
All right. Does anybody want to help me understand what they see in the picture? Or describe what they see in the picture? Okay, Sean says he thinks he sees an hour rod. He is correct. He does see an hour rod. It's right there. A little eosinophilic in the cytoplasm. So good, great job there. What would you guys say about these cells that you do see? So obviously these are red blood cells. Joe, perfect, right? Very large nuclei. So what does that tip you off? Are these immature or mature? What do you guys think? Large, fluffy nucleus. Very good, Joe and Rebecca. So these are immature cells, large nuclei, hour rod, and then in the stem, you're hearing about a patient who has what going on? What's going on with them? They've got petechiae, they're bleeding. What process could possibly be going on? And while you think about that, who votes for A as their answer? I think I got like 4 or 5 of that. Who thinks it's B? Who thinks it's C? Couple for C maybe. And then who thinks it's D? Great. Okay. The A's have it. The most likely diagnosis is APML. And some of you might be wondering to yourselves, well, what about ALL? How do I differentiate this from ALL? The hour rod does help you here because an hour rod is very specific for a myeloid lineage. That's why I changed it and put the picture there, just to reinforce that. ALL is a lymphoblastic lineage, so it does not have hour rods, does not have granules. So that does help you differentiate the two, which is kind of interesting, I find. But yes, very good job, everybody. The answer here is APML, which will lead us right into our AML portion of the conversation. Just like before, what we were talking about MDS, AML is what's gonna help us with the identification of these abnormal cells is the cell surface markers, or the immunophenotype, the mutations, or the cytogenetics, right? Phenotype, cytogenetics, and the morphology under a microscope. And just like we were talking about before, the normal cell division is going to lead this cell down this track. In MDS, right, we were talking about this, we have dysplastic cells. These cells are not progressing along this normal differentiation. If those MDS cells or those abnormal cells in any other circumstance acquire more mutations, then this process of these cells kind of like being shunted back and creating more blasts and shunted, undergoing cell division through like, synthesis and, G1S, G2M, all that stuff, mitosis, and becoming more and more blasts. If you have a mutation that essentially will arrest any sort of regulation of the cell cycle, you're going to go crazy and make a lot of blasts. And that is going to crowd out your other cell lines, right? So remember your myeloblast here, your precursor cell gives rise to the white blood cells over here. It's also giving rise to some red blood cells, and it's going to give rise to some platelets. So if we have so many blasts, it's going to crowd out these cells and outcompete them for resources. So then our RBC precursors and our platelet precursors go down. So you develop cytopenias. And then at the same time, these blasts will start filling up the bone marrow and may peripheralize, enter the blood. So you might see both a white blood cell count that's low or even high, depending on where you're catching the disease. Okay, so that's kind of like the pathophysiology of AML. And thinking about like ALL, just while we're at it, just remember it's like a slightly different cell lineage, right? You got the lymphocyte precursor that can either become a large lymphocyte or a small lymphocyte. The large lymphocytes can become NK cells, and the small lymphocytes can become either T or B cells. And these guys are going to go and mature, like in the thymus and that kind of stuff. So when it comes to like ALL, these are diseases that typically are diseases of the young. And AML, I think of that as a disease of the old. The reason I think it helps me kind of reconcile that is AML, the precursor to AML is MDS. And it could be MDS, it also could be other therapy-related AMLs and all that stuff, and we'll talk about that in a second. But MDS, by its definition being like this slow-growing, mutation-acquiring process, the longer somebody lives, the more mutations they're going to acquire, the higher the likelihood that we're not going to have differentiation of these cells. We're going to enter this kind of abnormal blastic phase. And definitionally speaking, remember MDS is less than 20% blasts. AML, therefore, is greater than 20%. And for ALL, although definitionally speaking, greater than 20% blasts is our cutoff for ALL as well, there really isn't an MDS for ALL. There's something called lymphoblastic lymphoma, which is defined as blasts less than 20%, but typically, definitionally speaking, you don't really need a full bone marrow to if you identify lymphoblasts in the peripheral blood, that this is ALL, because both of these diseases are treated very similarly. So thinking about T lymphoblastic lymphoma, B lymphoblastic lymphoma, same for ALL, they're really treated very similarly. And we'll talk about ALL in a nutshell later too. Okay, so AML, just like we talked about for MDS, when it comes to AML, same thing, right? Primary causes of AML are there could be congenital, these are genetic mutations that can be acquired from the environment or congenitally. Secondary causes is, AML that could be a transformation from a preceding disease. So I gave you one of them previously. So MDS, we already know, can cause AML. What other diseases could become AML? And I'll give you a hint. Think about what I first said when we were talking about the diagnostic schema of the bone marrow. What kind of mutations can arise and change cell proliferation? At least I hope that's a hint. So what do you guys think? What's another cause of AML? And this is the kind of stuff that as a medicine doctor we need to know, because then we can identify those patients who need to be evaluated for AML based on their history. Rashi, what do you think?
Rashi is currently charting, so I don't think she heard the question, but if you could repeat it.
So I'm asking for secondary causes of AML, and I'm glad that you volunteered yourself, Amanda.
I was also reading an EKG, so I didn't. I don't know.
I'll give you guys a hint. So some of the things that I think about are like these myeloproliferative disorders. Remember those guys? The MPNs. So some of those, remember mutations either will speed up cell division or slow it down. And those mutations do speed it up. And if we acquire more mutations later on in the disease course, they can transform to AML. Because all AML is just its excessive proliferation of abnormal cells. So Candace is right on the money. CML can transform into AML. It can have a blastic phase. Even polycythemia vera, although it's more common that it becomes myelofibrosis, it can still become AML. And then, exposure to chemo or radiation, just like before, can cause AML too by essentially expediting the acquiring of these mutations, right? When it comes to presenting symptoms, it's very similar to MDS, because what these patients are going to develop is, like that chronic fatigue, the anemias, that kind of thing. But AML obviously is a diagnostic imperative. This is a medical emergency if present. So the reason it's a medical emergency is because these patients can have a lot of complications. The previous question alluded to one of them. Patients with AML can develop DIC. But what are another couple of complications that can arise from AML? Thinking back to what do you monitor for patients when they first come into the hospital when they have a presumptive diagnosis of AML or when they first start therapy?
Like TLS.
Perfect, exactly. So TLS. What's another thing that you guys monitor very closely in the hospital, patients with AML? Especially paying attention to their vitals and their temperature curve.
Neutropenic fever.
Very good. Yes, exactly. So infection, right? Very high risk of infection. You don't have any white blood cells. You're neutropenic all the time. And there is another one that I would say is like we don't see it that commonly, but even like hyper leukocytosis, when your white blood count is greater than 100,000, 50,000, and you're having like end organ damage, the confusion, pulmonary symptoms, that kind of thing. Those are like kind of emergencies as well, and they might need leukapheresis, that kind of thing. Okay, so looking at a diagnostic approach to patients with AML, we're going to start off. Every patient deserves that same like MDS workup, and then as before, we do need that bone marrow biopsy and flow to help identify the type. Because until you have a flow cytometry that is giving you the immunophenotype, honestly, you really, cannot definitively say if this is ALL or AML. Because under a microscope, they look the same. They're just these immature cells, right? unless they have those characteristic features like those arrow routes, that kind of thing. Okay. Once we have a presumptive diagnosis of AML, we also use that kind of little bit more specific information that we talked about with like the cell, like the cytogenetics, that kind of thing, to help define the class. So way back in med school, you might have seen like the French, American, British classes, like from M0 to M7, based off of what they look like under a microscope. But now that we have more detailed information, we can divide AML into 4 subclasses based on the WHO. Does anybody know any of them? Thinking about how we classify AML. I'll give you one of them. It's AML that's not otherwise specified. Always my favorite category. AML can be defined with, AML with recurrent genetic abnormalities. AML secondary to MDS, and AML secondary to therapy. Why do we do this? Is because this actually gives us a lot of prognostic information. The longer you've had a disease, the more mutations, and this is, for all cancers, the longer you've had a disease, the more mutations you acquire. More mutations is bad. And any disease that was a precursor from MDS has had more time to acquire mutations and become more refractory of a disease. So these 2 categories, both therapy related and MDS related, are very poor prognosis, because these have typically more mutations and are refractory to first-line therapy. AML with recurrent genetic abnormalities is important because based off of the type of genetic mutation, it can give us not just prognostic information, but therapy information too. So does anybody know any translocations or mutations that are classic for AML? You can type them in the chat or unmute yourselves. I know you guys know this. You guys answered a question about, okay, so FLT3, Eric, good one to think about. Yep. So there's the FLT, FLT3. Sean Riley with a great one, yes, in version 16. What about APML? Run X1, I see. P53, I see. Very good. So what about APML? What translocation is APML? You have to know this for your boards. I'll give you the first half. Very good, Sean. So translocation 1517, or the PML RARA gene. Okay, in version 16. And then the last one that you need to know is, or not need to know, but is classic in AML is 821. The reason I bring that up is these 3 mutations. It doesn't matter how many blasts you have. If you see this mutation, you could have 2% blasts, doesn't matter. You have a diagnosis of AML. All 3 of these diseases is diagnostic of AML as a standalone mutation, which I think is fascinating. 1517, and the reason, their therapy is effective. 1517 is a very favorable prognosis because this is treated very differently than any other type of AML. And I'm sure you guys remember it, but just to see, either type it in the chat or unmute yourselves. How do you treat APML?
Natro.
Yes, very good. So the treatment of APML is ATRA and arsenic, all trans-retinoic acid. And that's with curative intent. So, you know, with these kind of mutations in mind, you know, they help kind of subcategorize somebody as having favorable prognosis or unfavorable. You know, having these three mutations is a good thing. Having more mutations is always bad. So having, like, in addition to that, P53 or FLT3, these are bad guys. RUNX1 is bad. The only other two that are good prognoses are biallelic CEBA and NPM1. So these are the 5 good mutations in AML. You don't necessarily have to know them, but seeing them is, you know, on those path reports can help make sense of it. So AML secondary to MDS. If you think back to our classification of MDS, there was that one very classic mutation that we associated with MDS. So anybody who has this like 5q minus when it's an AML is considered a bad thing. So any, like, you know, 5 or chromosome 7 mutations, we help classify into that category. And if they had a known history of MDS prior to their new diagnosis of AML, they'll fit into that category. And like we said, those are poor prognoses. And AML secondary to treatment, the only thing I really want you guys to know is what kind of therapies or chemotherapies specifically can cause AML. There's 2 that I think about. What do you guys think? You can put them in the chat or you can unmute yourselves. So what kind of chemotherapies could lead to AML? I'm just thinking about classes of chemotherapy. And again, as medicine docs, this is going to be helpful for us because if we see somebody who has a history of some sort of cancer, might have been treated with this type of agent, you know, we might think that they're at a higher or lower risk of getting AML. So good guess, Rashi. She says anthracyclines. Any other takers, guessers? So the 2 types of therapies to know is, one is alkylating agents. Alkylating agents. And this is things like cyclophosphamide, that kind of stuff. And the other one are topoisomerase inhibitors. Isomerase inhibitors. These 2 guys are very, you know, highly mutagenic. You know, topoisomerase, that's like a DNA enzyme. So if you mess with that, it's not going to be able to do proper proofreading of DNA. So obviously lots of mutations. Typically the timeline, just so you guys know, alkylating agents, about 5 to 7 years post-therapy is the highest incidence of AML post-alkylating agent exposure. And then for topoisomerase, it's easier. It's etoposide or topoisomerase. So it's about 2 years later after therapy, you typically see the incidence of things rise. And then this last category of NOS, that just refers to some of those like initial like French, American, British classifications that we're not able to you know, fit into a category here. Okay, so that's kind of like how to diagnostically approach and evaluate history-wise somebody who has AML. Thinking about therapy, there's a lot of nuance here that I don't want to go into too much, but as for medicine doctors, I think what we need to know is who to treat. So this is going to be anybody who is fit enough to get treatment, right? Because this is a medical emergency, and our intent should be, so the goal of therapy is complete remission and hopefully cure if we can. Pre-treatment considerations. So, you know, there's a lot to think about here, but anybody who's been on Blue 1-2, what's kind of some of the stuff that you guys always look for in patients before you just start them on chemo? obviously we need to account for the patient's goals of care, but in addition to that, any specific organ systems or diagnostic studies that you want to make sure you get on all of your patients before they start? Yes, exactly. So Eric, very good. Candace also, yeah, everybody should probably get an echo if their therapy is going to be anthracycline based, and anthracyclines are like doxorubicin, blah blah blah, any of the rubicins. And before we talk about the therapy, I just want to make sure we are all on the same page about what these terms mean, because on our Blue One rotations, or even in patients who had a history of AML, they might mention these terms. And so if they say the word induction, does anybody know what induction means in terms of chemotherapy? What are we trying to induce? So the goal of induction chemotherapy is to induce remission. And what is remission is essentially, once you've given like this first line chemo, you then wait a little bit for the bone marrow to recover, you do another biopsy, and you check under the microscope to see how many blasts are there. And if there's less than 5%, you think, oh, the chemo is working, we have achieved remission. And remission is not the same thing as cure. Every patient who achieves remission should then move on to the next step of chemotherapy, which is called consolidation. And essentially consolidation primes their bone marrow again for possibly like a transplant and that kind of thing. So consolidation is more chemo, and it's at different agents, usually high dose cytarabine. And then reinduction is if after induction you check the bone marrow and it's not, if it's greater than 5% blasts, then that means that the chemo didn't work. So we try to reinduce them with like high intensity chemotherapy. As far as agents are concerned, again, typically the first line treatment is treat the mutations that you can, and then make sure it's in line with their goals of care, right? So check mutations, goals of care. So for 1517, we always give these patients Atra, and arsenic. For patients who have IDH, again, you don't have to know this. You can give them like ivosidenib and inacidenib. So for your IDH mutations, IDH 1 and 2. For FLT3 mutations, these are the patients that can get like midostaurin. Patients with like CD33 can get like gemtuzumab. But what it really comes down to is identifying patients who are fit or unfit. There isn't a specific age cutoff, but usually what we see is patients who have a new diagnosis of AML that like for the first time they're coming in and they're over the age of 60, they typically have worse outcomes. And if they are under the age of 60, they have a higher chance of getting cured. So I think it's about 80% of patients under 60 will achieve remission, whereas above 60, it's only about 5 to 15%. So you can see age does play a factor, but there isn't a hard cutoff. So I just divided this into either fit or unfit. So in patients who are medically fit, the way I think about this is that means they can handle really high intensity chemo. So the first line treatment for them is what you hear about all the time, this 7+3. And things are changing and there's new evidence, but for now, what guidelines would say that 7+3 is first line for these medically fit patients. And what that means is 7 days of cytarabine, and it's a 24-hour infusion, so they just continuously get cytarabine. And 3 days, so for the first 3 days, for day 1, 2, and 3, they get an anthracycline, and that's something like, that like donorubicin. And these are cardiotoxic. So that's why we always check an echo in all of these patients to make sure that, they don't have pre-existing heart failure, that kind of thing. They can handle that chemotherapy. For patients who are medically unfit, the newest evidence would tell you that actually the first line treatment, does anybody know? For medically unfit patients. So these are not patients who are like frail, who are not going to give chemo to. They're patients who have like essentially medical comorbidities. Their performance status might be borderline, but they're not like not chemo candidates. Does anybody know? Vyxeos is a great guess. Vyxeos is essentially liposomal 7+3, and it's given over over 5 days on day 1, 3, and 5, and it's liposomal. It's very similar agents, cytarabine and anthracycline. So it's a good guess. Very recent articles from like New England Journal and stuff, and clinical trials, the first-line treatment is actually a hypomethylating agent with venetoclax. And second-line agents are either, if you have them, like IDH inhibitors, venetoclax alone if you have it, or even a hypomethylating agent alone if you have it, for these medically unfit patients. And if they become fit, then you can think about doing induction with like a 7+3. Consolidation chemotherapy, first line is typically high dose, that's what the HI stands for, high dose D, Ara-C, which stands for cytarabine. And ultimately, the decision needs to be made of whether or not this patient should go to transplant. And the decision-making that goes into that is essentially, are they at increased risk of relapse? If your risk of relapse is high, or your prognosis is poor, then we really have one shot of trying to cure you, right? With all the first-line chemotherapies. If you fail those first-line chemotherapies, the chances of you ever getting cured, of this disease getting better, drop dramatically. So if the chances of relapsing disease is high, then our intent initially will be try to take you to transplant. Yeah, I hope that makes sense. So, and if the risk of relapse is low, then it behooves us to say, well, your disease is probably not going to progress. It's not going to relapse. We don't need to take you to transplant. Usually those are like really young patients who just have like, translocation 15, 17, really favorable prognosis. We give them Atra, we give them arsenic, they get cured, they're better, they don't need a transplant. But if people have multiple mutations, more and more the definition of poor prognosis is expanded. But essentially, those are the patients that we try to take to transplant early. And the type of transplant is typically an allo, not an auto. Does anybody know why? And this is typically asked on mixed activity. Oh, wow, we're already over time. So I'm just going to answer my own question. The allo transplants have a very nice effect of graft versus leukemia. So this has a normal intact somebody else's immune system, so they can help identify that like kind of floating around couple of cells of leukemia and kill them off. So that graft versus leukemia effect is really nice. From a medicine perspective, just to round this off and the discussion very quickly, the other stuff that we need to consider when somebody's on therapy is prophylaxis against infection, because infection is always something that we worry a lot about. And the three types of infection that we worry about is viral, fungal, and bacterial. When it comes to viral infections, the agents that we worry about are like HSV, PZV. When it comes to fungal, we worry about Aspergillus, and if they have a lot of mucosal disease, Candida. And when it comes to bacterial, we worry about gram negatives, specifically Pseudomonas. So as far as prophylaxis is concerned, we just think about an agent that is oral, that is active against these bugs. And I would love to, ask you guys each of them, but just to give you guys the answer, typically acyclovir, HOSA or voriconazole, and quinolone. These two medications, both fungal and bacterial prophylaxis, are reserved for patients according to the IDSA guidelines that we're expecting for their neutropenia to be greater than 7 days and severe. So I think IDSA will say less than 100. Up to date will tell you less than 500. So if you're expecting somebody to have neutropenia for more than 7 days, which is essentially everybody who gets AML induction therapy, they'll be neutropenic for a month. They deserve to be on both fungal and bacterial prophylaxis. All right. I'm going to end it there. Any last questions? Lots to talk about, huh? It was so much fun having a nice little discussion about leukemia, MDS. Thank you, everyone. We'll see you again next time. All right. Hit the stop record, I think, right?
I send it.
Okay, leave meeting.